or if we're seeing extra mucus in their stool as well. It helps with the diagnosis. Imaging studies, contrast barium, so that barium enema study, you guys know what that is? Have you seen any x-rays with it? So it's basically a barium, so it's a liquid medication given through the rectum in an enema form, and it shows up on that x-ray super white, so they can see where there's narrowing, if they have any of those strictures from like our Crohn's patients, and you can get a really good view of what's going on in there. It's hard to see that, and if you've seen x-rays of bowel, you know, if they've got a lot of gas and bloating, you can't really see if there's much narrowing in there. Small bowel series, those are x-rays. So, like I said, it's harder to see, but they might start with some of those, and then if they can't really tell what's going on, they'll go ahead and schedule the barium enema series. CT, MRI. You know, they usually will go to CT before they go to MRI, just because of the expense of that, but if they really can't tell what's going on, MRI is going to get a good picture. But not usually what they go right to. And then, of course, colonoscopy, which you saw in the video. And then there's this capsule endoscopy, which reminds me of what's that movie with the guy who shrunk himself and ended up in somebody's body and was floating around. That's like what that is. What was that?
I think about the magic school bus.
Yeah, there's that. That's for a different generation. But that's basically, it's the camera in a capsule that can, I think I've only heard of it once. I don't know if they even really still do this, but that is something they could do. Because they can't, with scopes, you can't get past the duodenum on the upper end, so you really can't see the small bowel any other way. But still cool that exists, huh?
But they go through their poop until we find it.
Yes.
Yeah.
Yes. Yep. Yeah. Kind of like when the dog gets into something. Oh, yeah, there's the engagement ring. Not me. Complications. So hemorrhage, strictures. Which one has strictures? Which Crohn's or ulcerative? Crohn's typically. Because in that small bowel, you really don't have much diameter to work with in the small bowel. But you can have narrowing and scarring with ulcerative colitis too. Perforation. What's perforation? A hole. Okay, so all that pressure and that inflammation, you get a hole in the bowel. Which then, what happens when you've got a hole? You leak dirty into sterile. And then what can happen after that? Sepsis, yeah. So abscess, what's an abscess? Infection, yep. Fistulas we talked about, so that has to do with that inflammation can create those little tunnels, and it can connect with other organs. And so what other organs could be involved if we've got a fistula going on, small bowel or low? What else? More anterior. We usually have lots of problems with infections, bladder. Yes, so that's an area where we can have some of those fissures or fistulas, not fissures, fistulas. So they create a tunneling. So now you've got stool that can go into the bladder, and it can migrate up the kidneys. And now you got pyelonephritis. So yeah, it's poor people, right? So CDI. Oh. I'm not sure what CDI is. I'll have to do that. Oh, C. diff infection. There we go. C. diff. Thank you. C. difficile infection. So that's we have that flora, normal flora in our gut. The C. diff is when it becomes infection, it's an overgrowth of that C. difficile that's normally in your gut, right? So most folks this is an autoimmune, right? So they might be on an immune suppressant medication, which then can give an environment for all that normal flora to go out of control. And that's where they get the C. diff infection. Colonic dilation or toxic megacolon. That sounds so, I had to come up with some names still there. So what do you think that is? colonic dilation, stretching, yep, big. Toxic megacolon. Mega, big, yes. So if you look at an x-ray, I think yeah, it's, holy crap, exactly. So there it is. So this, I believe, is, yeah, this is with the ulcerative colitis. So you can see, this is the left side. So this is that, we're going backwards here. It's just created all that backup and stretch and inflammation. High risk for colorectal cancer, obviously screening, systemic complications. These are some other minor, this is all from your book, get into a lot more details. Malabsorption, liver disease, osteoporosis, that's the nutritional piece of it too, right? Routine liver function tests, they could fistulate to your liver as well. Bone density scanning, having to do with that osteoporosis piece and that lack of those nutrients, and help with the osteoblasts and clasts and your calcium absorption. So your goals, you're gonna rest the bowel, right? Try not to irritate it. Control inflammation, prevent infection or treat it, correct malnutrition. Is it all making sense? Right? Relieve the symptoms, obviously. That would be more the patient's priority, right? And quality of life. So the drug therapy, sorry, we were talking about this, how we're going to target their symptoms, and there's certain niche, like drugs that we would start out with. We wouldn't go right to all of these. Obviously, we would probably start with the inflammatory process first. So your aminosalicylates, the 5-ASA drug category. And then if that's not helping them, they might go ahead and give them some corticosteroids, prednisone. But we've got issues with that because this is chronic, right? So we can't be on corticosteroids. Can't be on corticosteroids their whole life, right? You're gonna have complications with that. So if that's not working, then we look at immunosuppressants. So now you can kind of think back to your cancer lecture and how do we treat patients who are immunocompromised, right? Those considerations, no live vaccines if they're on immunosuppressants. We've talked about antimicrobials for that overgrowth, right? The bacterial, gut bacteria. And then there's the biologic therapy that helps with some of the inflammatory processes and those proteins, and they work in that way to kind of decrease inflammation. Not very common, but typical biologic therapy requires somebody to go through TB testing because some of those medications might cause a flare-up of tuberculosis if they have the dormant TB. And of course you can use them alone or all in combination. It's just going to depend on how the patient responds to the initial treatment. And that's the general idea of what I'm looking for with medications, is understand, especially that we're going to reduce inflammation. We do that through those, the 5-ASAs, the corticosteroids, and then of course, when that doesn't work, we got to stop their immune system from attacking itself. So each of these slides goes in a little bit more detail, gives you some examples of what's in this drug class. So sulfasalazine, that's an old medication. They used to give that for arthritis, and they realized it works for this too. So yay. And then there's some people are allergic to sulfa, so there's a couple of medications, but primarily sulfasalazine. That's probably one of the first ones they're going to put somebody with these diseases on. Oh, and you can give these orally or rectally, so right to the source. Yay. Especially if you've got, which one? Ulcerative or Crohn's? Ulcerative, because it's usually on that distal end, right? Corticosteroids, prednisone, prednisolone, hydrocortisone, budesonide, decreases inflammation, primarily when we give that. Yes? For test purposes, we will put the meds that are specific on your blueprint when we make that available. but it's usually not gonna take up the majority of the questions on that topic. Helpful for acute flare-ups, so again, just to get them through those short periods, but they're not gonna be on it chronically, short-term use because of those side effects. Immunosuppressants, cyclosporine, and methotrexate. Remember methotrexate? So we're kind of overlapping a little bit here. Okay. Suppresses the immune response. What else? CDC monitoring, right? Because we're going to watch those numbers go down. They're not likely to be on such a high dose that we throw them into a neutropenic state, not to overlap with our oncology a little bit here. There's different dosing that we can do with these medications to just treat that up to the point where they're in remission and what doses works for them to get them through that piece. And of course, if they're pregnant, we don't want to give methotrexate. Why? That's the butyric acid, right? Okay. Surgical therapy for ulcerative colitis. So they can remove the colon, and this is the only way this is curable, is complete removal. So they could get a total proctocolectomy with an ileal pouch and an anal, or with like the J pouch too. They can create one of those. I have a picture, I think, in another slide. Or they can do that total proctocolectomy with permanent ileostomy. So the entire colon is gone, but now what's the ileostomy? Do you know? Well, it could be, depending on how much they remove. Usually it would be lower right. Why? They remove the entire colon. That's where the distal end of the small bowel is in that lower right quadrant. But you remove the entire colon, and ileostomy is a small bowel stoma, not large bowel. Okay. Now it depends on if any of that small bowel was affected. Usually it's just the colon with ulcerative colitis. So unless they remove the entire thing, recurrence is still common. So if they just remove like the descending and they maybe do a J pouch, they can still have ulcerative colitis. Because again, there's this familial genetic piece. They can have more flare-ups. So sometimes they go in for multiple surgeries until the whole thing's gone. So it all depends on what's been affected. Do we have dead bowel that we need to remove because of the complications, the inflammation? Has it completely lost all of its blood flow, and now they've got to take the whole thing out? So here's the picture. They can take and make a little pouch here that is called a J pouch. And they'll just kind of put an incision in on the sides and attach together to make one big piece that can store the stool temporarily. Sometimes, it depends on the type of stoma, but sometimes they can go in and actually evacuate the bowel like through like an enema and flush it out, or it just continually leaks, but it gives them some continence time. You can put like a cap, a stoma cap over it and let it collect in that pouch until you're ready to empty it. So there's a lot that's evolved in surgeries to help people live a better life, give them a little bit more time. But these are kind of nice to have for them. So that's when the whole colon is gone and they make that J pouch with part of the small bowel. Okay, for Crohn's disease. So again, this is like that situation. They can remove a certain piece if they have to, or if the stricture is so bad we've lost blood flow and they have to remove that piece of the bowel, and they can kind of take the two healthy portions on either end of that piece they removed and connect them until you kind of run out of space. So if you do that too much on the small bowel, you end up with short bowel syndrome, which we're going to talk about here in just a second. But yeah, difficult to maintain hydration and nutrition, especially if the small bowel's affected. So if we're removing all that, they're definitely going to have problems with that absorption and less mileage, I guess, of that small bowel to do all that absorption. And then there's that strictureplasties where they can open up some of that narrowing and maybe remove some of that scar tissue. And just kind of give them a little bit more time. Maybe if that tissue isn't unhealthy, they can open it up some. Okay. So that the complication, so short bowel is a complication of surgery, when we've removed too much, or if we've lost the mucosal layer to our gut and we have less surface area to absorb our nutrients with, right? It occurs 75% of small when 75% of that small intestine is gone. They're down to like nothing. So resection of the ileum, ileocecal valve, or colon causes a faster transit and decreased absorption time, right? So we want all that mileage of that small bowel to give our body plenty of time to grab everything it needs out of that stool before it then leaves the chat. So here's a little bit of what it looks like. They've done some surgeries, and now we're left with our stoma and shortcut. Chronic diarrhea, right? Because it hasn't had enough time to absorb that water back into the system, into our body. Abdominal pain. What's steatorrhea? Fatty, yeah. Hasn't had a chance to digest that fat, so there's going to be fat in the stool. Malnutrition, weight loss. So you can think of some of the things, the monitoring you might be doing on some of these patients. Right. So if they're malnourished and dehydrated, what kind of assessment might we do for some of those on the daily? Besides vital signs, diet, daily weight. Vitamin and mineral deficiencies, bacterial overgrowth. Again, this is repeat, right? Repetitive. So small meals, your sense another repeat here too. 6 to 8 small meals per day, control the diarrhea, replace nutrition loss, right? Hydration, high protein and carb diet, right? Because they don't have a lot of space to work with, so we're going to give them lots of those nutrients to let them absorb what they can. Low fat and low fiber. And some supplements. Sometimes parenteral nutrition, so that's that PPN or the CPN or TPN, parenteral nutrition or central parenteral nutrition, because we need to get those nutrients into their bloodstream, so that's a direct way to feed them straight into the bloodstream. That's what that TPN piece is, so that we can let that gut rest. So this is usually right after surgery. It might be on TPN or PPN. And they can do an intestinal transplant. So we transplant livers, we transplant kidneys, we can transplant intestine too. Okay, I'm going to skip through the plan of care. It's kind of all the same thing, just put into a care plan for you. So if you have a patient in clinical, you can refer to some of this, but these are all these pieces that we've been talking about. What's your plan? Maintain normal fluid and electrolyte balance. So there's one of our priorities is that hydration too. So sometimes if they have a lot of nutritional loss and hydration loss, and we want them to go into surgery, we're going to have to boost that up first. So sometimes that delays their surgery. That's an AI picture. I was like, I need a picture with some lean meat and white rice. It looks so fake. Okay, so provide adequate nutrition without exacerbating symptoms. That's kind of a big meal. I hope I wouldn't feed somebody that. But carrots are pretty good. You can peel them and cook them, and they're nice and soft and easy to digest. Of course, we talked about fluid and electrolytes. This is just kind of a place to put it all together for you. So some of our goals for nutrition. Where do we have our deficiencies? So we're going to be replacing all those losses, sodium, potassium. So enteral feedings are preferred. So if we can do tube feeding, it's still going to involve the gut. So sometimes we skip that part, we go right to parenteral feedings. But if we can do enteral feedings, it helps, it's easier to digest. So even if solid food is not something that they're tolerating, we can go right to enteral feedings, because that's a little bit easier to tolerate when you have some working bowel. But again, post-operatively, when we want complete bowel rest, they're likely going to be on some kind of peripheral nutrition for a while, or parenteral. These are all the same stuff we've been talking about. Patient education. So we need to teach them about diet, of course, right? About their medications and what to expect from some of these, especially if they're on immunosuppressants. This kind of involves the IBS as well, the stress reduction piece, psychotherapy, behavioral therapy. And there are some like foundations out there. This is good to connect people to, especially if it's a new diagnosis and they're having a hard time dealing with it. There are lots of foundations with information, patient teaching. You can go to those websites and pull out pamphlets for patients and print things off for them. That's always really helpful. It gives them something to kind of think about, read and mull over, or obviously if they need help with the reading, or sometimes there's Spanish and other foreign language patient teaching that you can provide for them too. So we want to decrease their symptoms. This is what we would expect on their evaluation. I use the same picture a lot. Stock photos. Be free from pain and discomfort. Use effective coping strategies. So this will help you in your care planning. So if you have any bowel or GI patients, you can go through your slides here. Do y'all need another break before we switch to peds?
Yes.
Yes? All right. All right, 3 o'clock.